women about the performance of their care team in communicating together, whether they worked well as a team, whether the care providers involved in providing their care communicated well with each other, and whether women said they received consistent advice from different care providers, which we know is actually quite important to women's overall feeling of confidence throughout their care. And you can see here that the same patterns of performance between models emerge. So there's clearly superior ratings for private obstetric and public midwifery continuity models. So that's the blue and green bars shown here. And I guess it does make sense that having fewer people coordinating your care should make these kinds of areas of performance easier, but it does suggest that if we are going to continue offering those other models, that we probably do need to pay greater attention to improving these particular aspects of care that are around, you know, the functioning of the care team as a whole and communication between different components of the care team. In these findings, the performance of labour and birth care is about equivalent for GP shared care and standard public care, so that's the red and the purple bars shown on these graphs, which makes more sense considering the delivery of labour and birth care is quite comparable for the women in those two models. The researcher in me feels the need to point out that the differences that I've shown here in women's experiences aren't necessarily attributable to the differences in care delivery in whole. So model of care may not be the only cause of the perceived better performance in certain models. There are some other factors that are potentially at play here. We know from other research that there is a halo effect when women get to choose the specific person who is providing their care. That is that just by virtue of having chosen the person who's providing your care, you are more likely to positively rate the care provided by them. There is also the possibility that some of these findings might be an artefact of women's ability to negotiate better access to the model of care that they want, and also having an ability to negotiate other aspects of care that they want. So it might be, and we're going to talk about access to different models of care later, it might just be that those women who are already more empowered might have more opportunity to access the models of care that they want and see as more desirable, and also to access higher quality of care from their care providers. So how involved are women in decisions about their model of care? You know, are women given an opportunity to actually be engaged in that decision-making process? So here our gatekeeper system of access for most models, and I think some of the other speakers are going to talk about the way in which these models are accessed, but primarily it's GPs that are providing access to the models at the first point of entry or referral. And that particular system means that GPs are absolutely critical, play a very critical role in either enabling or restricting the amount of information that are given to women about the available models and their relative features or benefits, and also in making sure that women do have the capacity to play a role and possibly be responsible for the final decision about the model of care that they're actually referred to. And you can see here, I guess, just confirming the importance of GPs, that in Metro North, at least among women who are birthing in public facilities, the vast majority are seeing a GP first in their pregnancy to discuss potential next steps for their care delivery. So on this graph, I'm showing the models that women in Metro North specifically recall being mentioned by their GP. So more than 60% of women recalled that GP shared care was discussed with them as a possibility, and at the other end, only 12% of women reported their GP discussing private midwifery care. Again, please remember that this data is from women who birthed at the end of 2012, so it is actually about 2 years on from the time that this conversation is likely to happen. It's just the best data that we have on this at the moment. At that time though, I should say that there was still only about 8% of women in Metro North who reported all of the models being discussed, and actually 9% who said that no, their GP didn't discuss any available models with them prior to referring them to a model of care. We've done quite a lot of work on these processes, and what we also found is that when there were fewer models discussed, so only 1 or 2, that those that were considered continuity models, but that's including GP shared care, private obstetric care and public midwifery continuity models, were more likely to be discussed, except private midwifery, which was almost never discussed, regardless of how many different models were talked about in that conversation. So we have done some subsequent work on this, and these are just some findings from a subsequent survey of women in Queensland done much more recently to find out what they most want to know in making a decision about their model of care. And these are some of the top ranked items. I've put there what their particular ranking is. I guess the point is that when time is limited, if it is, that a comparison between models on at least these particular aspects should be prioritised so that women can actually start to think about making an informed decision about their model of care. You can see here in blue that several aspects of continuity made the top 10 list. So things like, will I have at least one care provider who cares for me for my entire labour and birth? Will I have met the person who provides my labour and birth care before? So those findings would suggest that these are things that women find quite important in terms of being allocated to a model of care. Or choosing a model of care, which should be our goal. So to improve the quality of women's allocation to model of care, I think we'd all agree it's about the best possible match between women's needs and preferences and the particular features of the models of care that we have available. But to do that, I think we do need to pay particular attention to how information is shared. And by that I mean the way in which information is shared with women, but also between GPs and hospital and health services. Each of those has a very important role to play in ensuring that the best match is possible for all women. And also understanding how each one needs this communication to happen is probably an ongoing area of attention as the evidence about the strengths of each model and also the availability of some of these models is increasing. So I think we need to look at what each of them need in terms of, hospitals and health services potentially sharing information about the models that they're currently offering and make sure that that's current, and sharing that with consumers and with GPs. That consumers have the ability and capacity to share their needs and preferences as part of those referral processes, and that GPs share their information on available models and outcomes in discussions with consumers, and that they provide good quality referral information about the patients that they're referring to hospitals and health services. And I guess I'd like some conversations, I'm hoping some conversations might happen about how this communication can happen for everybody that's involved in that process. The Queensland Centre for Mothers and Babies has also developed a number of different tools and resources that you can use in care delivery to try to encourage being informed, using evidence and involving women in all of these decision-making processes. In particular, Birthplace, which allows you to search on the performance of every facility across Queensland in some of the indicators I've talked about today, but many others. Hopefully you're also all familiar with the facility reports on performance on these women-centred aspects of care, and there are some floating around on the tables. Feel free to take one of those with you. There's some tools and training modules for improving communication between care providers and consumers, but also between different care providers on the care team. And just a bit of a coming soon heads up alert, we are in the midst of developing a new model of care decision aid, so that much like Birthplace compares outcomes across the different facilities for birth, that will actually allow women to have evidence that's locally relevant to compare outcomes for the different models of care that are available. Thank you very much for listening.